Our skull is an incredible piece of natural engineering. It's a solid, bony vault designed specifically to protect the most important organ we have, our brain. But what happens when that fortress, that very thing designed for protection, becomes a trap? Today, we're diving into the incredibly high-stakes world of elevated intracranial pressure. And this is really the central question, isn't it? It's the terrifying paradox we're going to explore. When there's no more room to swell, no place left to expand, the brain finds itself in a fight for its own life against the very structure meant to keep it safe. Okay, so let's start with the absolute basics. Intracranial pressure, you'll hear it called ICP, is just what it sounds like, the pressure inside the skull. A pretty good way to think about it is like the air pressure inside a tire. Now, in a healthy adult who's just lying down, that pressure is normally pretty low, somewhere in the ballpark of 7 to 15 millimeters of mercury. That's our baseline. That's our happy place. Now, here's the number that really matters in an emergency. When that ICP number climbs up and stays above 20 millimeters of mercury, well, that's when all the alarm bells start going off. That is the critical red line, the threshold where doctors know they have to step in, and they have to do it fast. So to really get why that number is so critical, we need to understand the fundamental problem. And it all boils down to one simple, unchangeable fact. The adult skull is a closed, rigid box. And this slide illustrates that problem perfectly. It's something called the Monroe-Kelly doctrine. It's a fancy name, but the idea is actually super simple. Inside that fixed bony box, you've got three main things: brain tissue itself, the cerebrospinal fluid it floats in, and the blood flowing through it. For the pressure to stay normal, those three have to be in perfect balance. If one of them increases in size, let's say the brain starts to swell, one of the others has to decrease to make room. Something's got to give. And for a little while, the brain is really good at this. It can compensate. It can squeeze out a little bit of that fluid or some blood to make extra space. And so the pressure only goes up very slowly, but there is a tipping point. And once all those little compensatory tricks are used up, the system is completely out of options. At that point, even the tiniest, most minuscule increase in volume causes a massive, dangerous, exponential spike in pressure. This is the cliff edge that doctors are desperately trying to stay away from. So this gets to the heart of it. Why is all this pressure so bad? It's all because of this one simple formula. Cerebral perfusion pressure, or CPP, is the force that's actually pushing life-giving, oxygenated blood into the brain. You calculate it by taking the mean arterial pressure, your average blood pressure, and subtracting the intracranial pressure. So you can see right away, if that ICP number goes up and your blood pressure stays the same, your CPP goes down. The brain is literally being squeezed so hard that fresh blood can't get in, and that leads to oxygen starvation, which is called ischemia. So with stakes this incredibly high, how do clinicians actually spot the problem? Let's take a look at what they're looking for, the signs and symptoms. In the beginning, the signs can be kind of general. As the pressure builds, a person might just complain of a really bad headache, feel nauseous, or start vomiting. But there's this really ominous sign, something that shows up late in the game, called Cushing's reflex. It's this bizarre triad of things happening at once. The blood pressure goes way up, but the heart rate drops and gets really slow, and their breathing pattern becomes totally erratic. When a doctor sees that, they know the brainstem itself is under extreme distress. Now, to keep track of a patient's level of consciousness in an objective way, clinicians use something called the Glasgow Coma Scale. It's a standardized way to score a patient's responses. They check things like, do their eyes open when you talk to them? Can they answer a question and make sense? Can they follow a command like squeezing your hand? Each response gets points. A perfect score is 15, and the lowest you can get is a 3. It's a vital tool for tracking, minute by minute, whether a patient is getting better or worse. If the pressure gets too high and isn't stopped, you get the absolute worst-case scenario, brain herniation. This is when parts of the brain are literally physically pushed and squeezed into spaces where they do not belong. For example, in something called an uncal herniation, a part of the temporal lobe gets shoved downward, and it often crushes the nerve that controls the pupil on that same side. The result? That pupil blows wide open. It is a catastrophic physical sign of extreme unchecked pressure. And you can see this devastation on a CT scan. What's so powerful here is the comparison. On the left, that's a normal brain. See how it's symmetrical, and you can see those dark, fluid-filled spaces? Okay, now look to the right. The whole structure is pushed over to one side. Those fluid spaces are squeezed completely shut. This is the visual proof, the smoking gun of that immense pressure building up inside the skull. So once this problem is identified, how is it managed? Well, the approach isn't just one single thing. It's systematic, it's tiered, and it always starts with the least invasive options first. This is the first line toolkit. It begins with really simple things, like just elevating the head of the bed to use gravity to help drain fluid. Then, sedation is often used to calm the brain down, reduce its energy needs, and basically put it in a temporary rest mode. If that's not enough, then you start moving up to more powerful interventions, like special medications, osmotherapy, and even directly draining the excess fluid right out of the brain. The two big players in osmotherapy are mannitol and hypertonic saline. They both work by making the blood extra concentrated, which then pulls excess water out of the swollen brain tissue. But choosing between them isn't so simple. Mannitol can cause low blood pressure and kidney problems. Hypertonic saline has its own risks, mostly related to dangerously high sodium levels. The choice really depends on the specific patient and the clinical situation. Two other first-line therapies really deserve a quick spotlight. First, controlled hyperventilation. That's making the patient breathe faster. This causes the brain's blood vessels to tighten up, which can lower the pressure almost instantly. But it's a total double-edged sword. If you do it for too long, you can actually cause the ischemia you're trying to prevent. So it's a bridge, not a long-term solution. CSF drainage, on the other hand, is a much more direct fix. You literally put a small drain into the brain's fluid spaces and just let the excess drain out. But what happens when that entire first-line toolkit just isn't enough? What happens when the pressure keeps rising? Well, that's when clinicians have to turn to the most high-stakes, last resort options they have. This is the question that nobody wants to have to answer when the pressure is called refractory, meaning it just keeps climbing no matter what you throw it at. The choices that are left become much more drastic, and the potential trade-offs get much, much more severe. And this is the ultimate pressure relief valve. It's called a decompressive craniectomy. It's a major surgery where neurosurgeons actually remove a large piece of the skull, effectively opening up that closed box and giving the swollen brain physical room to expand outward. And we have data from a huge clinical trial called Rescue ICP that showed this procedure can be incredibly effective at saving lives. Just look at this chart. The mortality rate for patients who got the surgery was just under 27%. Now, compare that to the group who got standard care, their mortality was nearly 49%. That is an absolutely massive difference. But here is the incredibly difficult, heartbreaking trade-off. While way more patients survived after the surgery, a much higher percentage of those survivors were left in a vegetative state or with severe, lifelong disabilities. It saves a life, but it doesn't guarantee a quality of life. And this presents an unbelievably difficult decision for families and for the medical team. Beyond surgery, there are other advanced options. A barbiturate coma can be induced to basically shut down the brain's metabolism, which reduces its need for blood and therefore lowers the pressure. And there's also therapeutic hypothermia, cooling the patient's entire body down, which can also help. But both of these are reserved for only the most critical, most refractory situations. So when we boil it all down, what are the key things to take away from this? First, always remember the skull is a closed box, which makes any kind of swelling dangerous. Second, the entire goal of treatment is to protect that cerebral perfusion pressure, to keep blood flowing to the brain. Third, managing this is a step-by-step tiered process. And finally, and maybe most importantly, every single decision, especially in these later stages, involves a profound and difficult balance of risks and benefits. And this really leaves us with a final and pretty challenging thought. This whole battle against elevated ICP forces us to confront the very limits of what modern medicine can do. It's a field where the choices are almost never between a good outcome and a bad one. So often, it's a choice between a terrible outcome and a less terrible one. And it really forces us to ask, how do we, as clinicians, as families, as a society, how do we prepare ourselves to make these impossible choices?